This week on the BackTable podcast.
I was there in December. I don't even think I told you, Spencer, but I'm going back again in May to do
some
pediatric urology. So I'm meeting our pediatric urologist there. But of course, I was in Africa last June on a safari too, because Africa's become part of who we are. And so, I've taken my family, we've gone with old colleagues, and it's been, a great experience because the African people are amazing, and what you can experience in Africa and in many of the different countries I've been in, it's just been an incredible thing.
This host Silva is your host this week. Today we have two guests. We have Dr. Spencer Hiller. He's our endourologist here in Advent Health. He did a fellowship in University of Michigan. We have also Dr. Kenneth Peters. Dr. Peters completed his residency fellowship training at Belmont Hospital. Dr. Peters specializes in voiding dysfunction and female urology. He is currently professor and chair of urology at Auckland University William Belmont School of Medicine, and he is also the chair of urology at William Belmont University Hospital. Gentlemen, welcome back, table.
Thank you.
Thank you.
So today we're going to talk about a different aspect of medicine. It's one that we don't talk enough and we don't see enough. And it's not related to any specific disease. It's about giving back to the community. Hiller and Dr. Peters have been going to Africa for a couple of years now, and then we're going to talk about that. So, Dr. Peters, how did it start?
Well, it started about 18 years ago when I came home from work one day, and my wife was watching Oprah, and she was bawling her eyes out. And I walk in, and she's crying, and I'm like, what is the matter? And they were a story about vesicovaginal fistulas in these young women in Africa. And she was really moved by the story. And she turned on, she literally just jumped down my throat and says why don't you do something to help those women? And I was just I'd never thought about it before, but it got me thinking about it. And we thought, well, it would be a great thing to do. And if there was a way to organize a trip and try to help, that would be a good thing. And, that was kind of the start of the whole thing.
How was that process like? I mean, I'm sure it wasn't very simple.
It was it was the opposite of simple. It was very complicated because there was lots of logistics. I mean, first is, money, because to go, you need lots of medical supplies. I mean, it costs a lot to do these trips. And so it was finding philanthropy, because that's how we support this. And it's interesting how a trip like this can be a meaningful thing for a physician in training, because one of our old residents, his name is Mike Ingber, he's a urologist in New Jersey. He happened to go to Africa as part of his residency, because we allow our residents to go anywhere they want during their residency for a month to get a different experience. And he came back a changed man, and he started a foundation to support African mission work. And then he graduated, and, he now practices in New Jersey, and his family created, it's called Growing Hearts of Africa Foundation. And they've been supporting both the building of schools and medical mission work for a long time. And so I reached out to them, and they gave us the initial seed money to do a trip. But the money wasn't the only thing. The question is, where do you go? And we were hoping to do fistula work. And it is, over the years of going to our national meetings, like the AUA and stuff, you get to know some people. And Igor Vaz is a urologist in Mozambique who's a world-renowned fistula surgeon. And so I met him before. I reached out to him and I said, hey, have an interest in helping, and how can I help? And went ahead, and he said, come, and brought a resident with me. I'd never been to Africa. It was a little scary, didn't know what we were doing. And we showed up there, and, he met us at the airport, got us through customs, and that was the start of it. And it's a humbling thing, because you realize that we learned more our first few years than we provided them. I mean, because a fistula here is a simple thing, relative to Africa, where it's due to obstetric injury, and those are very complicated. And so we were very good at bringing medical supplies and being extra hands, but it took a few years to really be able to, I think, surgically be skilled enough to really make a difference for them.
And how you decided, because right now you're going to Monse, Zambia. Did you start it there, throughout this process, or you went to someplace else?
So our first 3 years were in Mozambique, but it wasn't ideal for us. It's a long trip, lots of cost. And we were in a big city and it was sort of like a VA. Everything started late, ended early, and it wasn't safe. And, my third year going, myself and Larry Searles, one of my colleagues, we were in Mozambique with two of our residents and we're walking along the street and some cops came up to us with their AK-47s. It was on a Sunday. There was nobody around and essentially robbed us of everything. The crazy thing is there was a reporter who was following us while we were there that week. And so they were meeting us every day in the OR. And I told them the story. And the next day, the front page of their newspaper had a huge story about how the police should be ashamed of themselves for what they did. And, they're here to help. But it was at a point where I said, okay, this isn't ideal.
Spencer, so Dr. Peters mentioned residency. So you started doing this when you were a resident. How did you get involved? What you started hearing stories of previous residents? How you started being part of this?
It's really a cherished part of residency at Beaumont, where I did my residency under Dr. Peters. And even before you start, but all 5 years of residency, you hear about this trip and how impactful it is on the residents that go on it. And so, you always go in your PGY 4 year. And so every year for the first 4 years, I'd see the residents go on this trip. And I knew what they were like surgically, not just surgically, but also, just from a maturity standpoint before they go on this trip. And then I could always see the difference when they came back. And it's an incredibly impactful trip from a training standpoint, from an experience standpoint, from a confidence standpoint. So, I was so excited going into it. And it lived up to expectations. It was so impactful for me that, as soon as I got back, said, hey, Dr. Peters, if I can stay involved in this in any way, please keep me in mind. And I said it to him enough times that it clearly, worked. It's not just a training side of things, but it also, you come back and you feel there's a sense of satisfaction and feeling like you're actually providing care that you can't really achieve in the United States, if you want me to be honest.
No, and I guess, you're providing care without worrying about insurance, you're just doing pure medicine. That probably the purest form of medicine that you can find is you taking time and doing it yourself without things that we were here in the hospitals. Dr. Peter, are all residents going when they're in fourth year or most of them go?
So most of them go. It's their choice. But over the years, there's been a few who didn't go for various reasons. It could be family issues or just chose not to, had some concern about going. I think now, early on, that was probably more the case. I think now, as Spencer said, everyone just looks forward to getting to that point because they hear nothing but positive things. And I think where we go in Monza now is such a good place to be, this is one of those trips that you leave there and you feel great about the care you provided, but I always see it as like good for the soul. It regrounds you of why you became a physician. You go there and you just care for people. Like you said, it doesn't matter about insurance. We're just providing free care. But I always come back like a better person. And even though every year I find it harder and harder because I'm getting older and older to do this trip and to work that hard. And, you come back and you say, can't wait to do it again next time.
And Spencer, as a resident, any specific preparation, to go to Africa? I never been to Africa, so I don't know, but any flu shots, yellow fever, how do you prepare for this?
Yeah, that's actually a great question. So the first time that I went, Beaumont had a travel clinic that I went to, and they ran down the list of these are the vaccinations you need, and to make sure that everything's up to date, they gave anti-malarial prophylaxis. They gave you any shots that you needed. They even gave me a sleeping pill for the airplane if I wanted it. After the first trip or so, I don't really do that anymore. I know what I need. I just make sure I have my anti-malarials. But yeah, there is a lot of preparation. I feel like that first trip, I bought so much gear for myself to prepare myself for that trip, thinking you don't know what to expect. And there's so much hype around it. And even though you hear the stories, I'm thinking, I got to buy my own mosquito net to sleep underneath. And I remember like my clothes, I dipped them in Prethrin. Yeah. And I soaked it in this mosquito stuff to make sure. And I mean, I haven't done that again since that first year, but yes, the hype and the excitement, and it's just, you get so into it. I mean, that's one aspect of it, but the other aspect of it is the surgical side of things. And this trip is well placed in your training at Beaumont in that, you're kind of just coming off of some pediatric urology where you learned a lot of surgical skills. You're just getting introduced to doing some more bigger cases, but you're not quite at the point that you're doing them independently. You know the steps, but you're not independent with it. And it allows for a rapid amount of growth in a short period of time. And so, yeah, everybody talks about you need to, what are the steps to doing an open, simple prostatectomy? Because that's one of the most common procedures we're doing over there. We'll talk more about what kind of things that we do, but absolutely, there's studying. I made sure I had my Hinmans on my phone that I could pull up and remind myself all the steps for whatever procedure I'm doing. And it's just the anticipation is almost part of the trip.
Peter, you mentioned that you were mugged, but any other challenges that you have encountered or you encounter at that point?
To me, the biggest challenges have been getting medical supplies there. You would think since you're coming to volunteer that there would be an easy way to do it. And when we were in Mozambique, it was all about paying off people. So we would go through customs. We'd actually get walked around the customs people because somebody would meet us there and pay somebody some money. But even in Zambia, to get medical supplies in is very difficult. And, we tried to do it the kind of appropriate way, filling out the appropriate paperwork and stuff. And the times that I did that, it always failed at customs. If you go into that something to declare line, even though you did all the paperwork, we lost everything. And to go all that way and not have, and when I would say everything, I mean, we were bringing all of our medical supplies in suitcases, and there would be like 7 or 8 suitcases, each weighing between 50 and 70 pounds. And so if you go and you lose all that, it's an incredible loss. I mean, cost-wise, it's tens of thousands, sometimes hundreds of thousands of dollars. I mean, we bring some really sophisticated medical equipment that we donate to the hospital. So what we became is quote unquote tourists, and we go there and say that we're just there on holiday. But here you are with 4 guys for a week with our carry-on bags, our backpacks, and like 7 suitcases full of medical supplies. So as you go through customs, now you're going through nothing to declare. And that's my biggest angst every year is how you get through customs. And of course, what did they do? They built a new airport. And what did they put in it? An x-ray machine. So all of a sudden the angst became even more. And I remember a couple of years ago, we were going through and somebody stopped us and they're like, what's in all those suitcases? And we're like, oh, we're going fishing. And they're like, oh, you're going fishing. Great. Have fun. This year the year before they took our suitcases and threw a couple of them on the x-ray. And thankfully they happen to be suitcases. So we bring like clothes and soccer balls and things for the kids, happen to be those suitcases and not the ones with a lot of medical supplies. So that's been my biggest challenge. But this past year, after all these years of doing this, I happened to meet a Jesuit priest in a village near where we are. And I went to see their hospital in their village. And we were talking about this. And he said, oh, I have the answer for you. And there's a service that it goes on a boat. So it takes like 4 months to get there. And he ships things from the United States all the time because he has a radio station he uses to teach the young folks in his community. And he puts like thousands and thousands of dollars of supplies in it. And I'm like, well, what about customs? He goes, I don't know. It just shows up. And he goes, I've done it for 20 years. And I'm like, all right. So he gave me the information. So this past year, we sent everything like in June and it showed up there in November and it worked. And so we had the easiest time this year because we just walked through customs with our, carry-on bags and the supplies were already there, picked up by a friend of mine and at the hospital. So that's been my biggest challenge. And the other one is just how to pay for it.
So Spencer, Dr. Peters mentioned that you guys are a week. Go through the process. I mean, how long does it take? How do you fly there? What do you take? What kind of? I mean, do you need to bring food? What do you pack?
It's a 2-week trip, 2 weeks of time that we're gone typically. 2 to 3 days are spent traveling there. And we've gone a couple different ways to get to Zambia, but we fly into Lusaka, their capital. We'll spend a night there kind of resting, and then we get into a car the next morning and drive another 3 to 4 hours to the actual city that we're in. In terms of preparation and things that we need to bring, I mean, historically, before this year and this great shipping container idea, you had to fit all of your clothes, any electronics, pretty much everything that you needed for yourself into a carry-on bag, because our check-in bags were taken up with medical equipment. And so I've gotten kind of accustomed to it. Even this year, when I could have checked bags of my stuff, I was like, well, I'm used to it. I've done it, 6 times now, 7 times now. So in addition to, the obvious clothes and rain jacket, I've kind of varied year to year what I bring, but I always bring like some protein bars because, meals are present and actually really good, but they're not quite as big as the typical American meal. And sometimes you have to skip a meal and you just want something quick. Always, obviously, like some bug spray, hats, that kind of stuff. Clothes are pretty bare bones because, I mean, for the week that we are in Monzi operating and seeing patients, I mean, you're wearing scrubs all day, every day. And you really just need, a pair of underwear and socks for each of those days and nothing else. You bring soap and shampoo with the hope that maybe you're going to get a shower, although that's not always guaranteed. And we've had good years and bad years with that. They are dependent on how bountiful the rain has been recently, whether or not they have running water. And so, this past year, we did not get many showers. And you are operating indoors without air conditioning. It's 100 degrees in that room, and it's not thin surgical gowns that you're wearing. It's these reusable thick cloth gowns. And so, I mean, each case, you are totally soaking yourself in sweat.
And that's in Monza, but in the capital, you have water.
Yeah, in the capital, we stay in a hotel. We have water.
So before you fly back, you get a nice shower so that your wife can open the door.
Oh, yeah. Yeah. At the end of the trip, which, I'll let Dr. Peters describe because that's really something that he's cultivated with time. But the end of the trip, we have a day or two of, R&R, pampering ourselves a little bit, touring around actually Livingstone, which is down in the southern part of the country at Victoria Falls, where we do like a safari and see some animals and then go see Victoria Falls.
And special cell phone. You're incommunicado for the time there, or?
It's gotten better over the years. I mean, this past year, I had cell service throughout the whole thing. I mean, sure, I have to get the international package, whatever it is, $10 a day or something like that. But to be able to communicate with my wife and find out how the kids are and get pictures, it's worth it. The time difference is very difficult in order to like FaceTime with family at home. It's just every time that they're available, it's either the middle of the night for me or it's the middle of the day and I'm operating. So I don't get much like talking live, but I text with my wife every single day. But when we first started going, my first year there, I remember I did not have cell service. Wi-Fi was spotty. We used to have to go sit out in this one specific part of the hospital that we knew we could use somebody's, Wi-Fi router that was present on the hospital, and it would only work sometimes. And the whole time you're using it, you're getting absolutely destroyed by mosquitoes and other bugs, and it's gotten better.
And Dr. Peters, in terms of procedures, what type of procedures you guys do? You mentioned that you started all this process because of fistulas. Spencer mentioned prostate. How do you decide what to do? How you prepare for that?
And so we started really with the concept of fistulas, and Dr. Searles, one of my colleagues, was coming with me. And at that time, there was a local physician there from the UK, Michael Breen, and he's a famous fistula surgeon, and he was in Monza for many years. And so we would come and do a lot of fistulas, but then they had all this need for general urology too. And what ended up happening is it kind of morphed because Dr. Breen left and moved to Madagascar. And what happened is he set up a couple fistula camps, one in Uganda and one in Angola. And so Dr. Searles broke off of us, and we sponsor also 2 fistula camps a year besides the Zambian camp. So the fistula camp, our female pelvic medicine fellows are invited to. So that's a 2-year fellowship. And Dr. Searles will go there with Dr. Breen. And so really this has become more voiding dysfunction and anything that walks through the door. So we take out kidneys, we do stones, we do a lot of prostates, a lot of stricture disease. And so what happens is when we get there, like we'll do that 3.5-hour drive, and we'll get there like on a Sunday, and we get unpacked, and then like 2 hours later, we're in a clinic seeing 120 people, and we see everybody in a day. And then we decide who can we help and who we can't. And then, the ones that we can help, we set up for surgery for the week. And, there's not a lot of it is clinical decision making. Like, we've taken out kidneys based on, palpating a mass in their abdomen and an ultrasound suggesting that there's something coming off the kidney. Their CAT scans are not common, not especially in that area. And most people can't afford to get them if there's available somewhere else. But, open simple prostatectomies, urethral strictures, and then we do, Frank Burks, one of my partners, comes and does those strictures. And then over the years, I've been able to get bipolar TERPs to do there. And so it's the only place in Zambia where you can consistently get a bipolar TERP. People come from all over.
Do you have a monitor or?
I do. I know I have a monitor.
Okay.
It was just a little television.
Okay.
And now it's actually a flat screen. It actually is decent. The equipment is incredibly old. Like, I'm always worried that like my lens is going to break, my camera's. So I'm always, whenever I hear that there's some equipment available somewhere, I grab it and store it away for Africa. But so we do a lot of that, but every year is different. Like, you don't know what you're going to do until you show up. And having good people there who've worked with us for all these years, they're now doing a lot of this on their own. Like, they're doing a simple prostatectomies, which they never did before. I don't let them touch my TERP stuff because that's irreplaceable equipment. But, things that we had taught them over the years. So now when we're seeing people, sometimes we're seeing like problems that occurred, on somebody that they were operating on, or the more complex patient, some crazy big fistula coming out from somebody's kidney to their skin, which Spencer got to enjoy recently, operating on there that, they weren't comfortable doing. So, but it is what you want it to be, which is sustainable, right? They're able to provide additional care to all these patients that they never were before because of the presence we've had there. And then we use the WhatsApp app to continue to communicate with them after we leave. So they'll, if there's a question about a patient, they'll send us a picture of a wound, they'll ask for some advice. And then over the year, they'll do that throughout the year. Somebody will come in with something and they'll reach out to us and say, this patient showed up, this is what's going on, what do you think? And so it's, technology has been very helpful in all of this too.
And do you see, you mentioned that you're doing bipolars. Is there a plan to continue bringing technology to the area?
I don't know that we can go much beyond, but I don't think a robot's going to work there because the electricity is out most of the time.
Yeah.
And that's true. And it's terrible with my butt. Like, if the power goes out and Spencer's operating, we could use headlights. If the power goes out and I'm in the middle of a huge bipolar TERP, because that's what they are. We decide a bipolar TERP based on a rectal exam. And it isn't about size like in the United States. Can I TERP this? It's about if it feels like cancer and hard as a rock that you can't do an open simple, they give those to me. It doesn't matter if it's a 30-gram prostate or a 300-gram prostate. I'm doing a bipolar TERP. And then Spencer's doing any benign feeling prostate that we could do open. And so that, the technology, like, I don't think laparoscopy is going to work there, but to their credit, the government has bought them. They do have like endoscopy now where they could do like a colonoscopy, upper endoscopy. The question is, what do you do with it when you find something, because there's no pathology, like to get a pathology report, it has to get sent to the capital and somebody has to pay for it. So there's a lot of limitations in care there.
And Spencer, you mentioned stones. I mean, you do just removing kidneys, or what are you doing for those?
Yeah, the stars would have to completely align to get like a ureteral stone there, and it's the perfect timing, and the patient shows up, and that kidney's not dead. Unfortunately, most of the time, if somebody has an obstructing stone, by the time they show up in the clinic and we're there, it's been there for years and the kidney's dead. And so we've certainly done nephrectomies for it. This year even, we had a plan for somebody that, had an ultrasound. Ultrasound showed a stone in the kidney, showed that had a KUB that showed a stone looking like it was in the region of the kidney. There was no hydro. It was a healthy kidney, and it looked like it was rolling around in the renal pelvis. So the ultrasound there isn't great. It's not reliable. And, we weren't sure if we were going to be doing a nephrectomy or maybe a open pyelolithotomy. And we ended up getting in there, could not feel a stone anywhere. Kidney sure looked really healthy. You can't do like an intraoperative ultrasound or anything like that. So we ended up just closing and saying, I'm not going to take out a totally healthy kidney. But I've certainly in the past done a nephrectomy for a complete staghorns there, because, it's just unfortunately there, you have to think about, is this patient, sure, we have other options to treat it in the United States. They're not going to be able to go and get a PCNL from someone else. And so, should I just be taking care of this kidney that's going to eventually fail? How do I take care of it best? How do I not harm people? I mean, we really try every time that we're trying to make a surgical decision, remember the do no harm motto and do our best to make sure that we're making these people better off, not worse off. Dr. Peters alluded to how we do have some pretty good continuity of care there and get feedback. And so, I just heard back that same patient that we did this planned, maybe an open pyelolithotomy, maybe a nephrectomy. Turns out they went and got a CAT scan and it's stones in the gallbladder or something like that. And turned out it wasn't a stone in the kidney and the ultrasound was wrong. And so I'm sure glad that we did not remove a totally healthy kidney in that scenario. And we had a long conversation about, how can we make sure that we're not harming these people or as little as possible. And then, we have done like reimplants of ureters. Maybe the most impactful part of this trip for me, or the most impactful surgery I think I've ever done, was a 7-year-old girl who had a duplicated collecting system, and she had a ureter inserting into her vagina. And she came in and was totally incontinent of urine. And incontinence is a very shunned upon disease state there. She would never find a spouse. She would never be welcomed into another family. She would, basically be shunned from society because of this. And we were able to identify, and this is, going back to, we were just coming off of pediatrics. My co-resident and I were able to do a nice low fan and steel incision, identify this aberrant ureter, reimplant it into the bladder, and she woke up the next day totally dry, and gave her a life where she would not have had one. So, that was just incredibly impactful experience.
So, Dr. Peters, you guys mentioned that first day, 120 patients in the clinic. And do you again do more clinic, or you, after those 120, you start just operating? Give us the rundown day by day on that process, on that week that you're there.
Typically Sunday, we see all those patients and we do a ton of rugs for anyone who can't urinate and has a suprapubic tube in, or is it in retention? Because is it a stricture or is it the prostate? And we wish we were done, but what ends up happening is the next day, then we set up a surgical schedule. We basically have 3 beds. One's an endoscopy room, and then we have 1 OR that we put 2 OR beds in next to each other. We just put a little sheet between them. And so we have basically 3 surgeries going. What happens continuously, though, is people keep showing up. They knew the clinic was supposed to be Sunday, but a lot of times people come from long distances and they spend whatever money they have, they get there because they hear we're there. And so we're being pulled all the time between cases to see other patients. Like, they'll come in right in the entrance of the operating room, and we're dropping somebody's pants and doing a rectal exam or a genital exam and getting a history as, they're prepping the next patient to be seen. So it's a continuous thing. At some point, we get so overwhelmed, we're like, look, it doesn't to see anybody else right now makes no sense, but it's a continual process.
And in terms of the hours that you are doing surgery, you start at 7 a.m. till 9 o'clock?
Yeah. So, typically rounds at 7, 6:45, 7, got to do it earlier and earlier as we do more cases because people usually don't go home the next day. So we overwhelm the hospital. And, surgery, we try to push them to get going, like patients on the table by 7:45. And every year and every day, we're like, okay, we're not going to work until dark. But it seems like they're always just wanting to put one more patient on. So it'll be, we'll get done 6, 7 o'clock at night. So, I mean, they're 12-hour days. And when I was younger, it was easier. It's not so much now, but we do as much as we can in the time that we have there.
Oh, that's incredible. And then Dr. Peters, or Spencer mentioned what you guys do after. So is that something that started 18 years ago or just evolved into taking those few days afterward for yourself?
It's since the beginning. I mean, when we were in Mozambique, we did something similar, but it's a long way to go to anywhere in Africa, and to take the residents. Many of them have, some of our residents never been out of the country before. So this to be their first international trip. And everyone works so incredibly hard. So we had to fly out of somewhere. And the only place that you could fly out of really is Lusaka or Livingstone. And we're right between the two of them. And so what I've been doing is we've been going down to Livingstone. So we'll take a car or a bus down there, and we'll stay at a little lodge for a couple nights on a river there. And, we go visit Victoria Falls. We go ahead and there's a little like walking safari there. So the residents get a little taste of a safari. But again, because I've been going so many years, I've gotten to know a lot of people. And a lot of people I've gotten to know are all the wood carvers around Victoria Falls, the people who sell all the African, wares to the tourists. And I've met a couple of them. And one of them, his name is Ernest, who's one of the greatest people I know. And that whole group lives in what's called the Mukuni village. And it's what I think the residents, and even myself, when I first went to Africa, expected. They live in, grass huts with, mud huts with grass roofs in the middle of nowhere as part of this village. And so over the years now, Ernest talked to me about all the needs that they have there, particularly around education for the kids. The schools are really limited, and to get out of poverty, you have to be educated. And in these remote villages, particularly, you can't, like, once you hit 8th grade, you'd have to walk 2 miles to school through an elephant corridor where kids get killed every year going to. And so that's when I teamed up again with Growing Hearts of Africa, and we've been building schools there. And it's been an amazing transition to see. So I take the residents with me to see that. And I'll let Spencer comment on it, but I think next to like being able to go there and do surgery, it's probably more impactful, or probably the thing that they like the most about going down to Livingstone than the safaris or Victoria Falls, but to be with those children and see the impact it's had.
So, Spencer, do you help do the schools, or Dr. Peters is doing it on a separate trip?
So, that's something that he's really taken on, which is just a testament to Dr. Peters' gigantic heart over there. Part of this trip is seeing how much somebody can give back to others and how much you can do. Seeing the way of life that people have in Mukuni village, you kind of didn't realize that that's a reality for people. And this is just one village in Africa. And it's pretty astonishing. And so I have done what I can with contributing for this trip, but no, I mean, that's Dr. Peters' baby over there. And he's a yes man. People have problems and he wants to help them and figure out a way to fix it. And he has put himself in a position to be able to do that with his connections and his wherewithal and his knowledge.
And Dr. Peters, funding, you mentioned that it's always a challenge. Right now, who's your main supporters, and what can you do to get more?
Yeah, so funding is always a challenge because, everyone says, oh, are you going with IVU or are you going with Doctors Without Borders? No, I mean, we're organizing everything ourselves. We're getting all the medical. I mean, as soon as one trip ends, start getting ready for the next trip. The initial funding, I got out of Growing Hearts for Africa. The last 12 years, we've been self-funding ourselves for these 2 fistula trips and this one. And we do local fundraising in the community. I've had some very generous patients who know that I do this every year, and they've been willing to step in and support it. We had no working anesthesia machine or patient monitors a couple years ago. I just had a patient, purchase 3 anesthesia machines for us. My goal now, because, my career is going to come to an end in the next 5 or 6 years. My goal now is to make this sustainable beyond me. And that's why, when Spencer, and I give him all the credit in the world for volunteering and be able to agreeing to come back and do this, is I'm trying to bring in younger, attending urologists as, because you can't just go there and not know the system and the people and how to make it work. And so now I feel like I have a good group of people who come every year, all of them trained at Beaumont. They're all one is here, Frank Burks, and then Jake Stevens is in Ohio and Spencer in Florida, who have agreed to come back. And so now it's about fun, how do we sustain this long term? So I'm just met with our foundation. We're trying to raise like a $3 million to endow so that we have money beyond me, because, I spend so much time just trying to raise funds. And so just had an initial meeting with the foundation and going to, work with the local community. I reached out to a couple of our, wealthy community supporters. And I mean, we'll see if we'll be able to do it, because not only like is it these trips, but you need an infrastructure there. And like, you could never go, there's not another hospital we could go to in Zambia except Monza to do what we do with, TERPs and open simples, because think about the fluid you need, right? Like you can never, like last year we went through almost 1,800 liters of saline. So where do you get that? You can't buy it there. So Monza Hospital happens to be the only hospital that has their own fluid production plant. They make their own IV fluids, and it's a hole in the wall little place, but the guys who run it know what they're doing, but it's at end of life. And so right now we're raising money, and Spencer's helping with this, trying to get funds to build them a new plant, get them new equipment, because if we lose that ability to have that fluid, we lose our ability to do what we do there. And, and the other infrastructure thing is, and we're talking about water and showers. Showers is an inconvenience for us, but there's no running water in the OR most of the time. So when you go to scrub, nothing comes out of the sink. I mean, somebody is pouring water that's probably dirty water from a pitcher onto your hands, making you feel good that you're scrubbing. But I just had a group that's based in Canada, but they do a lot of work in Africa, and they helped me get some boreholes and stuff at the schools that we're working on. And they just went there and analyzed the entire campus. And I'm waiting to hear what the nut's going to be. But the amount of work that needs to happen to create a sustainable and reliable water at the campus there of the hospital is an enormous amount of work, because the infrastructure has just collapsed over the years. And it's those kind of things that we're trying to raise money for too, so that we can make the community better, the hospital better. And so, we take money anywhere we can. I always tell the story because I had this little old lady I saw for years with interstitial cystitis, and she'd see me every December, once a year. I'd refill a couple medications, and every year she wrote me a $4,000 check for Africa. And about 5 years ago, she came in and wrote me her little check, and then said, Dr. Peters, just so you know, I met with the Beaumont Foundation and I left you $100,000 in my estate. And I said, because she goes, I want to be able to continue to support what you do beyond me. And I'm like, oh, that's nice. Well, she died like 18 months ago. And I got word from the foundation 6 months later that she actually changed her donation and left me her estate, which was $250,000. So that was a great initial nidus to kind of get some money in the bank to help support this. But we fundraise like with yoga. Like there's a yoga person in town, Johnny Kest, who's a great guy. He'll do a fundraiser for us, like just doing yoga in one day and raise like $10,000. Like it's crazy. So it's a lot of networking, and through Corewell Health and the Beaumont Foundation, people can donate online. We're getting QR codes made right now, so we can share QR codes with people where they could just point their phone and donate. But, I'm hoping that we can, continue to do what we're doing.
No, that's great work. And doctor, in terms of So if somebody wants to donate, they go straight to the website of Beaumont.
Yeah, so if you went, because Beaumont merged now into a bigger health system, it's called Corewell Health, but you could also put Beaumont Foundation, and you'll see that it'll say donate, and then there's a bunch of different things you could donate to, obviously a health system, but there's one that's called the Ingber Africa Fund. Michael Ingber was the one I told you initially, an old resident of ours. So that fund started, 18, 19 years ago. So that's the money that, the money gets directed to that fund. But if anyone wants to donate, feel free to just email me directly. It's kenneth.peters@corewellhealth.org, and I'll be happy to point you in the right direction.
And Doctor, how many times do you go to Africa in a year?
I was there in December. I don't even think I told you, Spencer, but I'm going back again in May to do
Doesn't surprise me.
Some pediatric urology. So I'm meeting our pediatric urologist there. But of course, I was in Africa last June on a safari too, because Africa's become part of who we are. And so, I've taken my family, we've gone with old colleagues, and it's been, a great experience because the African people are amazing, and what you can experience in Africa and in many of the different countries I've been in, it's just been an incredible thing. So, once a year for sure for medical mission work, sometimes twice a year, and then supporting 2 more fistula camps with Dr. Searles. So we have a presence there, from Beaumont in Africa for sure.
Spencer, do you want to add anything else?
Not that I haven't said already. Just reiterate that, this trip was something that really has happened out of Dr. Peters' true dedication to helping other people, and is just such a testament to what a fantastic guy that he is. I consider myself fortunate that I've been able to join this trip as a regular member, but none of it would happen without him.
And Doctor, if somebody will fund themselves to go there, are they welcome to the trip, or what's the status now?
Yeah, it's hard to expand it beyond us. Just there's a lot of limitations, the travel limitations. Like when we go from Lusaka to Monza, like we have like so many people and stuff can fit in a car. So I think that it would be difficult to invite or have anyone else along unless, and this has happened, a resident couldn't go or didn't want to go, and we've been able to bring on somebody else. But in general, I think the system works the way it is, and I'd love to expand it, but I don't think I can do much more than we're doing. So
that isn't to say there isn't more need there, though, right?
For sure.
And they have just because of the services that we provide. They need everything there. You name the service, they have a need for it.
Yeah, probably if you already established the system, it will be just it will be easier for somebody new coming in and doing it.
Yes, exactly.
Doctor, any last words for the audience?
Listen, I appreciate you doing a podcast on this. I know it's not the typical talking about, one of our medical diseases we take care of, but I think that this is equally important in helping others. And basically, I hope it motivates people to do what they can within themselves. Whether, maybe they can't travel to Africa, but they could support something like this, provide, medical supplies, things like that. So, if it inspires somebody to do something to help others, and it doesn't have to be there, it could be in the United States, but to use the skills that we've been given, to improve the quality of life of other people, I think that's kind of the true reason why we became physicians. So.
Well, thank you both for what you're doing. Thank you for being a guest in BackTable. So thank you.
Thanks, Jose.
All right. Thank you very much.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, DM us at _BackTable Euro on Instagram, LinkedIn, or X. BackTable is hosted by myself, Ruchika Talwar,
Jose Silva,
and Suzette Sutherland.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles,
Gabe DeGrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Chi Ding.
Administrative support provided by Judy Dela Cruz.
Thanks again for listening, and see you next week.